But yeah, so I'm here today to talk about one of perhaps the most commonly presented conditions in your general practice and how our research aims to tackle it. So this condition has no outward signs or symptoms, no associated pain, yet so serious that if left untreated leads to kidney disease, cardiovascular disease, stroke, and premature death. Any takers? It's hypertension, correct. And over 6 million Australians currently have hypertension. Now, of that group, 4.2 million are classified as having uncontrolled hypertension, which means despite hypertension being treatable and preventable, this group still struggle to maintain BP at optimal levels. An extremely vulnerable population, sometimes referred to as a ticking time bomb. But what if we could improve pressure? What if we had a new approach? An approach that was evidence-based, person-centered, and utilized general practice nursing to top of scope. Well, that's what our research set out to discover. We're conducting a randomised controlled trial to look at the impact of a nurse-led hypertension management intervention on improved BP, reduced cardiovascular risks, and overall enhanced health outcomes. Now, it sounds very promising, but previous to this, the evidence to support nurse-led clinics or nurse-led intervention in BP management is unclear. We haven't really reached any definitive conclusions. A systematic review of RCTs previously between the years of 2000 and 2017 revealed 11 papers, 11 studies. Now, of those studies, there was variable outcomes from no measurable impact on BP to statistically significant improvements in BP. So while this data is promising, it's also crying out for robust, warranted trials to explore the evidence of nurse impact upon hypertension management. So our trials warranted pilot data, which was conducted in Sydney in 2014 and 15, had some pretty positive outcome data from it. An in-group difference of 14 millimeters of mercury between group, and also reduced weight BMI and improved medication adherence. Now, contextually, the ImPress trial is warranted. We do know that nursing in general practice is growing. The numbers are growing. However, it's not connected to a growth in scope. Recent APNA report has revealed that 1 in 4 general practice nurses actually feel underutilized. Not only that, but they want to see other ways of maximizing their skill set. So this is where ImPress comes in. ImPress is a randomised controlled trial across 7 sites in southwest Sydney and southern Illawarra. Okay, our primary outcome is BP at 6 and 12 months, and secondary, we're measuring also SNAP. So SNAP is obviously, smoking, nutrition, alcohol and physical activity, BMI and medication adherence. All of this data is collected using validated tools. Now, we're at phase 1 of recruitment. We've got 7 general practices, 9 general practice nurses currently, and currently 76 patients, which I think we might have had a new recruit this morning, Liz, so we're doing quite well. So about the trial, PenCat was used to identify those patients within general practice that often remain hidden from healthcare with these criteria, that they had hypertension, age between 45 and 74, and we're at high cardiovascular disease risk. Okay. Now, if we have a look here. So we can see that the trial has got quite a robust theoretical base. Many of you will be familiar with Wagner or / Brodheimer's model. Okay. So we're actually working, which is I think is exciting about the ImPress project, is that we're working at both upstream and downstream elements. So when we're looking at the upstream elements here, we're really trying to concentrate on improving the delivery and system of design. And we're doing that by proactively identifying those individuals who typically would remain hidden in healthcare. And once these patients are invited, they then become on the radar, certainly the nurse radar. And then they're subject to more follow-up and ongoing support. Now, in the downstream elements, what it really focuses on is that GPN role optimization. at the beginning of the trial, general practice nurses were invited up to the University of Wollongong to receive tailored education to prepare for their role. Education involved digital upskilling, and as we've heard today, there is a lot of scope for nurses to get more involved in PPM, practice population management. So in preparation to identify those patients within their practice, they received quite bespoke PenCat education skills, but they also received ongoing mentorship from the research team going forward. They also received we were given them instruction and education around the Heart Foundation's latest guidelines in terms of lifestyle advice, and also best practice in management techniques and BP recording. Okay, where else have we got? They also had the opportunity to tailor their motivational interviewing techniques, because as we know, lifestyle advice is one thing, but how you enact it and hold space for a patient who is actually trying to get on board often quite entrenched lifestyle change, it certainly is a very skilled, advanced role. Now, effectively, nurses in this intervention were leading effective team-based care. And as the model suggests, once we actually are able to support patients to better self-manage, we have activated enhanced self-managed patients. So hopefully we'll end up with this role at the end once we evaluate. Okay, as you can see from this slide, the structure of the intervention was based on the 5A's model. Okay, do you know what? I might quickly look at the notes because there was quite a lot to cover here. Now, patients in the intervention arm were invited for a series of face-to-face nurse consultations over a 6-month period. And in that time, nurses identified all of the risks that were present for this individual, and all the subsequent visits then developed an action plan which was returned to, so they had structured self-management support to enact those lifestyle changes. Additionally, also patients did receive one general practitioner consultation, and that was focused on medical optimization in terms of their medications and a medication review. Some patients actually only saw the GP once in this whole period in the pilot, so it's showing that nurses really are leading the charge on this. Now, data collection, as I mentioned, are at key points at 6 and 12 months. Now, currently we're at the 3-month mark, and while we can't determine any statistical significance until we gain the full data set, we're actually beginning to see some initial clinical improvements. And I can share a case review with you today. As Robbie says, everybody loves a case study. Okay, so this is Kevin. We'll pull up a few bit of details about Kevin, but Kevin is an individual that you might see frequently in your general practice. Now, the thing about Kevin is that while you might see him frequently, I get to see patient data like Kevin's on a daily basis and in great number. And from that, I'm able to evaluate the direct impact that nursing care has on individual outcomes for people like Kevin. Now, let's have a look at pre-intervention, what he's at. Okay, SVP, this might be a familiar story for some of you. Okay, so we've got 3 months in. Okay, we've got a reduction in 22 of systolic blood pressure. Also a reduction in weight, that's 7.5, and also reductions in BMI. Now, what were Kevin's goals? Well, Kevin originally, and I will do him justice here because I've got some verbatim quotes for him, his initial goals were to exercise 1 time a week at the gym. Now, that has changed, and also to eat less salty junk food, as he says verbatim-wise. But 3 months in, his story's changed. He's going to the gym 3 times a week. He's also going swimming with the grandkids. He's increased his veggie consumption, and he's eating less processed salt-laden foods. And what he does this despite not having enough time at the shops to read all the bloody labels. So I think Kevin and his nurse sat down and talked about the perils of a high-sodium processed food diet. Now, there are lots of key achievements in the partnership between Kevin and his nurse. But one key achievement was the flexible appointments that were offered by the GPN. Now, Kevin never received a telephone call or a consult before 5:30 of an afternoon because Kevin's 60, Kevin still works and he hopes to continue being able to work for as long as he can. So we did set out to generate robust evidence of nurse impact on hypertension management, but we actually learned some key learnings along the way, one of which was that conducting a randomised controlled trial of this scope was exceedingly ambitious, but it was also impacting by several factors, workplace issues and interprofessional issues. Now, the recruitment was exceedingly complex in our case, and it revealed quite a lot about shared decision-making in general practice. Initially, nurses who were interested in coming forward and saying, yes, I'd like to participate, ended up having to decline because they weren't supported by their general practice managers' teams, like the managers or the GPs. So that was a bit disappointing. Time also factored into it. While ImPress was designed to fit into existing clinical routine, and it was also reimbursed, which was important, nurses did find it challenging to actually get that protected time. And again, it was something that we've heard in the conference today about practice managers, maybe the team not playing together, practice managers booking in too many scheduled appointments when it was supposed to be intervention time. But thankfully, they overcame this hurdle. And as nurses found their flow, became more attuned to implementing it into general practice, it went quite well. We had another challenge with hybrid data systems. Now, believe it or not, there are still paper file systems in New South Wales. So again, that was challenging, but researchers and nurses came together to get over these hurdles. So initial patient identification was challenging, but at this particular site, we actually found more patients here than anywhere else. Are you surprised? I'm not sure. Excellent. Now, the perspectives of nurses who participated in this particular research was interesting. Now, what stayed the same across all sites was that nurses had a shared motivation to improve patient outcomes. One of the nurses who works with us also works in a heart failure clinic. And she quotes, "I work in a heart failure clinic and see the result of not managing high blood pressure in general practice." Nurses also did see it as an extension of role, whereas before they met these individuals like Kevin and really had no recourse to follow up, they now had a chance to follow up. And one of my favorites is that one of the nurses really actually saw that their role in research was an opportunity to transform practice, improve patient outcomes, but also be part of a bigger change to primary care. It's really exciting to hopefully be part of a change to primary care, even if it's a long road ahead. Now, I think it will be a long road ahead, but we need to start thinking about, could models like this be sustainable going forward? Well, the pilot study seems to indicate so, with several practices electing to keep the model on, even after funding was pulled out when the research wagons rolled home. It really hinges on nurse-led activity hinges on sustainable workforce. And so issues of retention, recruitment and retention really need to be still investigated. In fact, in this time, we've been running for a year, we've had one nurse retire and 3 nurses leave their position for pastures new. Okay, our biggest roadblock obviously is the fee-for-service funding system currently operational in Australia. But as there is a slight nudge towards block funding, which was hinted today at our plenary session, and the fact that there's even wider calls for reform for a model that really encompasses team-based care, this is really going to see our nursing scope going up. Now, this is interesting because a recent article by Heel et al., GPs as well, but it's a great article, likened general practice research as building a bridge between the swamp and the ivory tower. But what ImPress demonstrates is that nurse researchers and nurse clinicians have an opportunity to build a different type of bridge, an iconic bridge, a bridge that connects 2 sides of the same story. So, as a nurse and as a researcher, I encourage you to take any opportunity you can to be involved in research. Don't wait for research to find you. If you have a good idea, don't sit on it, share it. We need your visibility, we need your voice, share your story, partner with researchers at university level to get this visibility and to get this story out. And again, for those of you that do participate in research, thank you, because together we are actually building the evidence base that will transform practice that will advance our profession, that will influence policy and overall improve patient outcomes. So thank you very much.
You've probably got, do you want to take any questions? Is there any questions for Catherine? Probably got time for... Yeah.
Still taking practices on?
I hope so. Where from? New South Wales? We would, again, it's gathering that evidence until... I heard today, what was it? It was the great quote, you've either got to bring a seat to the table or you'll end up on the table. And it's a part of making that robust evidence. The pilot went so well. Hopefully we'll get statistical significance from this project. So the greater sample size we can have, all the better, but we're hoping that it will gain momentum. But talk to us afterwards if you'd like to. Good roll. Awesome. Oh. Right, yes, and you know what, that was probably not quite clear. Is the question around who the participants were? Yes, they were registered nurses. We didn't actually include enrolled nurses because we specifically married it up to the professional scope of practice of a registered nurse in general practice. Thanks for that question. That should have been clearer, yes.